I think I'm just, my jet lag maybe just kicking in, but it's always good to be on a stage because that makes you less tired. So thank you for joining today. And we can have questions, maybe we can stop and have questions a couple of times during the presentation, so not just at the end. Okay, I don't have any financial disclosures, but as Suchi said, I was on the 2017 guidelines from the American Thyroid Association for the management of patients with thyroid disease during pregnancy. I am not on the new guidelines. I'm very glad to be off of these guidelines for the next version. Okay, what we'll try to do first is to recognize what is abnormal. You first have to define what is normal during pregnancy. And I actually noticed there's an abstract of this meeting from Taiwan that looks at normal ranges of TSH during pregnancy. And then once we recognize what is normal, we can define what is abnormal. And here we're not talking about an underactive thyroid, but maternal hyperthyroidism. So we'll discuss the evidence-based recommendations for treatment. And I will talk about PTU and the FDA. You just heard a lot about the FDA for artificial intelligence. But I'll talk about PTU and the FDA in the United States. And then how when we treat the mother, we are also, in essence, treating two patients. We're treating the fetus as well. And so we'll talk about testing for fetal or neonatal thyrotoxicosis. So first, when we're talking about pregnancy, there are a number of things that occur early in pregnancy that affect thyroid function tests. And the first thing that happens is thyroxine binding globulin, TBG, goes up. That happens early in the first trimester. And that's a result because of the elevated estrogen that changes the glycosylation of the protein, so there's less hepatic clearance. And then later in pregnancy, what happens is with the volume of distribution increasing in the mother, serum albumin decreases, and that affects measurement of free T4. So we have the increased total T4 and total T3 because of the TBG, and then the free T4 assay issues later in pregnancy. This is actually a paper that we did over 10 years ago now, but it shows, I think, nicely what we all know, which is the total T4 range, which most of us don't measure very much anymore, in the non-pregnant woman, which is shown in green, and then in the first, second, and third trimester of pregnancy, which are shown in the pink. And the box is the interquartile range, and the line is the median. And what you can see is that the total T4 increases really by 8 to 10 weeks of gestation, and that's really a reflection of the TBG, and then remains pretty stable, so that the normal total T4 in pregnancy is about 1.5 times the non-pregnant reference range. And then when we look at free T4, and again, these are two commercial assays, Alexis and Toso, but this holds for pretty much all of the commercial assays. Again, what's shown in the green is the non-pregnant reference range reported for that assay, with the median and the interquartile range. And then you can see that as pregnancy progresses, there's a relative decrease in the free T4. And what's really interesting is that you can see that if you compare the normal or the pregnancy range, especially in the third trimester, to the non-pregnant reference range. Oops, I just did something here. A screen showed up on my, I can't, can you help me? I can't see. Wait. I got rid of it. Okay. I must have hit something. So that what happens is that as the pregnancy progresses, especially with the, let me take this off a sec. Okay. Especially with the Toso assay, that you can see that if you compare the lower limit of the non-pregnant reference range to the Toso assay, which is on the far right, almost 80% of pregnant free T4 values in the third trimester would be considered abnormal. So how the assay performs during pregnancy compared to the non-pregnant reference range is also variable. And so it's really important to try to use trimester-specific ranges for free T4. The other thing that happens is we all know that HCG is the pregnancy hormone, and HCG has cross-reactivity or similar protein structure as TSH, and that as HCG increases, this is mirrored by this decrease in TSH. So what you can see here from a paper that is now almost 30 years old, but one of the papers that established our understanding reciprocal changes of TSH and HCG is that in the first trimester when TSH peaks, shown here in the dotted line, sorry, HCG peaks, shown in the dotted line, TSH drops and naters. And then as pregnancy progresses and the HCG returns to normal, the TSH comes up. But this is really important because we know that the structural homology of HCG and TSH is very similar. What makes them different is their beta subunit. They share an alpha subunit. And so therefore the HCG protein can bind to the TSH receptor by a receptor spillover mechanism. And if you look at a correlation, this is cross-sectional, of women between about 10 and 14 weeks gestation, and you correlate the free T4, which is shown on the y-axis, with the HCG, you can see that as the HCG increases, the free T4 increases. Okay, so then what is a normal TSH during pregnancy? Well, obviously, whenever possible, you should use trimester-specific reference ranges that have optimal iodine intake and negative TPO antibodies, and that is the recommendation on the poster from Taiwan as well. But that is very aspirational because we don't always have that. And so until 2016, both the Endocrine Society and the American Thyroid Association put up these upper limit normal reference ranges, that the first trimester should be less than 2.5, and the second trimester onward should be less than 3. And this is just wrong. And since then, there have been at least 15 population studies done. Many of them have been done in areas where women are iodine replete, and they found something a little bit different. So what they found is that if you do not have a pregnancy-specific reference range, in the first trimester, you should reduce the upper limit of normal, called ULN, by about 0.5, and the poster from Taiwan recommends that it goes down by about 1. And even if you do that around 1, it still isn't quite as low as 2.5. And the lower limit should go down by about 0.4. So that maybe in the first trimester, the reference range might be 0.1 to 4. But most importantly, in the second and third trimesters, the TSH gradually returns to the non-pregnant reference range. So with that then, let's turn to a case, a real case. It was fun because this was someone that I saw on the consult service about 19 months ago. So I used to be able to say I saw this patient 2 weeks ago, 2 months ago, but now it's a little bit longer. But we were actually called to the emergency room on a Saturday night because there was a 22-year-old female, a gravida 1, who was 12 and a half weeks gestation, and she'd been vomiting since she was around 8 weeks pregnant. And she noticed that especially over the last 24 hours, she couldn't even take anything by mouth, and she was vomiting. There was no family history of thyroid disease, and before hydration, always important to measure, to know the hydration status when you're measuring someone's pulse. Her heart rate was 120 beats per minute. Her blood pressure was 108/70. Her weight was 176 pounds. But importantly, 4 weeks earlier, her weight was 187 pounds. So she actually had lost weight with this. She had no signs of Graves' orbitopathy. Her thyroid was non-tender. It was the upper limit of normal size, and there were no nodules. Okay, and these are her thyroid function tests. Her TSH is undetectable. Her total T4 was 24 with an upper limit of normal of 11.5. Her free T4 was 3.1 with an upper limit of normal of 1.7, and her total T3 was 226 with an upper limit normal of 175. So what do you advise? So this is where it gets a little, you can raise your hands. We don't have audience response here. So your options are to start PTU, to start methimazole, nothing, and recheck thyroid function test in 2 weeks, or to do something else. So how many of you would start with PTU? Nobody. A couple of people. Okay, how many of you would start with methimazole? A couple of people. How many of you would just recheck her TFTs in 2 weeks? Somewhere. How many of you would do something else? Yeah, I think we need some more for diagnosis here. So this is gestational thyrotoxicosis, but obviously rechecking TFTs in 2 weeks is fine, but you're in the emergency room. So there's a couple of things that you can do. So just to remind you that because HCG increases thyroid hormone production, it has been shown that if you're having multiple gestations, you are more likely to have this HCG-mediated increase in thyroid hormone production. You normally don't have to treat it, but certainly for those of you who've taken care of women with molar pregnancies, those women can be frankly thyroid toxic. And sometimes it's the one time that you actually do want to get some supersaturated potassium iodide or some type of inorganic iodide on board, have the woman take that, and maybe even give her a dose of PTU, and as soon as the mole's evacuated, things will get better. But women can go into storm if their thyroid function tests are very abnormal and their HCG is in the millions. Not very common. But this obviously occurs when HCG peaks, which is the end of the first trimester and the early second trimester, and it improves as HCG decreases. And it's actually interesting biochemically because not all HCG is made the same. So some HCG is less glycosylated, it's more basic, and it's actually more active. But it turns out that in gestational thyrotoxicosis, HCG is actually more glycosylated, more acidic, and it's less active, but it's more long-lived. So it lasts a longer time. So overall, you're getting one of those, it's like having low glycemic index food, where the area under the curve may actually be a little bit bigger because it's lasting a little bit longer. And there's no indication for antithyroid drugs. So this is, again, all of the new data has been in hypothyroidism. So when you talk about hyperthyroidism, you really have to dig back in the literature, but it gives a lot of very good insights. And this is actually a paper that was done at LA County, which is the public hospital in Los Angeles. And what they did was they looked at about 60 women who were pregnant, and presented with some type of vomiting. They compared them to the controls who were non-vomiting women at the end of the first trimester. But the women who were vomiting were divided into 3 groups, shown in orange, pink, and red. So vomiting alone, hyperemesis, and severe hyperemesis. And hyperemesis was defined as less than 16 weeks gestation, vomiting with weight loss, and large ketonuria, whereas severe hyperemesis, those women had LFT abnormalities or they had electrolytes that did not normalize after hydration. And what you can see is, let me first show you, our woman obviously belongs here. She has hyperemesis with weight loss, but her liver function tests were normal. And what you can see is that with each of these, the TSH goes down, the free T4 goes up, and the HCG is the highest in the group with the severe hyperemesis. So is there a way that you can separate gestational thyrotoxicosis from Graves' disease? And I think the first thing is we know in our non-pregnant patients, nausea and emesis are not generally symptoms of Graves' disease. Thyrotoxic symptoms are variably present in both. Certainly, I made the point that she was tachycardic, but it got better after she was hydrated. But women with gestational thyrotoxicosis still can remain tachycardic. You won't have the autoimmune findings of Graves' disease, and most importantly, you won't have presence of a TSH receptor antibody. I think one of the most helpful things is looking at the T3, T4 ratio in conventional units, nanograms per micrograms, and if it's less than 20 to 1, that's more consistent with gestational thyrotoxicosis. And then most importantly is the ultrasound. So you can never ask me to give a talk without talking about thyroid ultrasound. And we're very fortunate in the United States, and I'm sure here too, that the ED physicians now do point-of-service ultrasound. So even if you don't have your own ultrasound when you go to the emergency room, you can go pick up someone else's ultrasound and you can put it on the patient's thyroid, and that's probably one of the easiest ways to determine the difference. Because unless there's some concomitant Hashimoto's, which can happen, the thyroid should have normal echogenicity and not be vascular, as opposed to Graves' disease, where it's enlarged, heterogeneous, because of the autoimmune Graves and vascular. So this was our patient. The fellow and I put the ultrasound on. Her thyroid was normal size and echogenicity. It wasn't vascular. We calculated the T3, T4 ratio based upon the numbers I gave you. And then we drew a trab, but that doesn't come back until 4 days later, and it was negative. So my point in saying something else was just to point out, certainly rechecking her thyroid tests in 2 weeks is totally appropriate. But if you have an ultrasound that's available, it's also a very easy way to differentiate. And I think the reason it's important is that I don't know if many of you feel the same pressure we do from our obstetricians that they really want to treat. And so if you can have another tool to explain that you don't think that it's Graves' disease, it's very helpful. So think about the ultrasound. So with gestational thyrotoxicosis, this will generally get better after 15 weeks gestation. Okay, so any questions about gestational thyrotoxicosis before we turn to Graves' disease?
I totally agree with your recommendation of running an ultrasound for this case because because nowadays pocket ultrasound or portable ultrasound are very easily available. But however, considering that goiter is one of the typical pregnancy change, so instead of measuring or observing about the size of the thyroid, is there any other sign like the echogenicity, texture, anything else to differentiate between these two conditions? Thank you.
Thank you for your question. So first, I'd like to just come back to what you said about pregnancy and goiter. So that's how the Egyptians used to tell that women were pregnant, because they got goiters because they were iodine insufficient. However, there's an abstract at this meeting that talks about the iodine health of the population of Taiwan as being quite good. So I suspect that many of you are not seeing just goiter as part of pregnancy. So during pregnancy, the thyroid has to make about 40% more thyroid hormone, so that if a woman is living in an area that's not iodine sufficient, and there may be an immigrant population here. So in the United States, we still can sometimes see a goiter in pregnancy with people who have been born and lived internationally and come to the United States. That's the reason for the goiter, is because the thyroid, there's not enough iodine, which is actually just a really important thing to say here as well. We're not talking about hypothyroidism, but it's critical that when women get pregnant, they are counseled that they should take a prenatal vitamin that has iodine. In the United States, studies have been done, and about 40% of prenatal vitamins do not have iodine. So it's just very important to make sure they take iodine. So coming back to your point, it's what I said, the most important thing is the echo texture, and because Graves is autoimmune, you will see a heterogeneous texture. I did make a little subtle point where I said that since autoimmune thyroid disease, thyroid peroxidase antibodies can be present in up to 12 to 14% of women in their reproductive years, you could have someone who has a little autoimmunity present because they have two things that are unrelated. They have gestational thyrotoxicosis, and they have a background of lymphocytic thyroiditis where they might be hypothyroid when they're 50. But they're not going to have that increased vascularity that you see in Graves. So point-of-service ultrasound is fantastic. We actually have the butterfly that plugs into my iPhone now, so we don't even have to borrow the emergency room ultrasound anymore. So it's really easy. We can just take that. It's a great ultrasound tool. But it's a great plug for prenatal vitamins and iodine. Was there another question?
Professor, I have an interesting case that came to me just yesterday. She has history of Graves' disease and treated by antithyroid drug for a year and a half, and complete treatment. So her thyroid function returned to normal, and her TSH receptor antibody back to normal. And when she came to me a month ago, she told me that she wanted to get pregnant. So I tested her free T4 and total T4 and TSH and thyroid TSH receptor antibody. And we don't know at the time she is already pregnant for 5 weeks. So after 4 weeks, she came back. We saw that her TSH is lower than normal limit, and her free T4 and the total T4 were greater than upper limit, and her total T4 is above 1.5 upper limit. Yeah, and her TSH receptor antibody elevated, and we both know that before her conception, her TSH receptor autoantibody come back to normal, and she already saw the report on our app. Our hospital's app, she can check her function on our hospital's app. Then she had a retract just before she came to me, and so that was when she was pregnant for 8 weeks, and her thyroid function declined gradually, and her TSH receptor antibody came back to normal. And I don't know how to explain such a condition. Thank you.
I would go, I guess the practical answer is I would go with the most recent tests, and we'll talk a little bit about pregnancy. and what you do for Graves' disease, that's a very nice transition to the next part of the talk. But the practical answer is I would go with what the most recent tests are and what's going on clinically and continue to follow her. And I would probably, this is someone, we'll talk about the TSH receptor antibodies. You probably will have to recheck it later in pregnancy because of the fetal risk. But I have seen a quick flip, but not when it's followed in pregnancy that quickly over a 4 to 5 week. If anything, there's autoimmune exacerbation in the first trimester. But I think the practical answer is go with the most recent tests, especially if she's doing well. Okay, so that's a great introduction to the most common etiology of maternal thyrotoxicosis is Graves' disease. And these are the abbreviations that I'll be using: ATD for antithyroid drug, PTU, methimazole, and carbimazole. I know all 3 drugs are available here in Taiwan, and you know carbimazole is about 60% of methimazole, but we basically do 50% because it's easier most of the time. There are other causes of maternal thyrotoxicosis, toxic nodules. We just talked about gestational thyrotoxicosis, recovery from postpartum thyroiditis. So I see this quite frequently. Someone has a miscarriage 7, 8, 10, 12 weeks earlier, and then they conceive, and you check their thyroid function tests, and they're thyrotoxic, and it turns out they're in the thyrotoxic phase of lymphocytic autoimmune transient thyroiditis. And then obviously we have to remember sometimes people take too much thyroid hormone. Okay, so I was talking to people who told me this is not such a big deal in Taiwan. Is that true, that nobody here really cares about what the FDA says? Maybe for AI, but you don't care about you don't leave. So I have to deal with my lawyers, so you don't get sued if you keep a woman on PTU in the first trimester. Okay, so we don't do this anymore because of the FDA. So prior to 2010, PTU was the preferred drug in pregnancy. What happened in 2010 was the FDA published this box warning about liver injury and acute liver failure with PTU. It also published that there were birth defects with first trimester methimazole. So it didn't say for everybody. It's just that PTU then may be the treatment of choice during or just prior to the first trimester, and then you switch over to it may be the treatment of choice at the time someone wants to conceive, and then potentially during the period of organogenesis. And that's the guidance we have. So it's very hard to keep someone on PTU entirely in pregnancy once organogenesis is ended, when the FDA has told us that maybe we shouldn't be doing that. So let's talk a little bit about methimazole embryopathy, because this is the reason why, this is the rationale for why many people don't use methimazole during the time of organogenesis. So this is the picture on the upper left is from actually the first reference. This is choanal atresia, which has to do with failure of the development of the nasal passages. And so there can be some issues breathing, but it's never life-threatening. And then this is aplasia cutis. This is actually a baby that was seen at the Brigham. This is an ectodermal defect. Unfortunately, it generally only affects skin. It doesn't affect the bone. There are sporadic cases where it's affected the bone, and those babies have died if there's been a vaginal delivery because of cranial hemorrhage. That's never happened with methimazole aplasia cutis. But it's an ectodermal defect, and it heals with sort of an eschar and old area. But from the full spectrum of methimazole embryopathy is this esophageal atresia, these omphaloceles, these omphalomesenteric duct anomalies, which require surgery. And it turns out, this is from the Danish registry that had over 800,000 children in it. And they looked at the incidence of this methimazole embryopathy, and there's a background risk of 0.07%. And if you take PTU in the first trimester, it's 3 times higher. But then you could look, if you take methimazole, it's significantly higher. It's 8 times more. It's almost 25 times higher if you take methimazole. So there certainly is an increased risk with methimazole, but there is even more with PTU. And if you actually review the literature, it turns out that the key time for exposure is between 7 and 10 weeks. And then this dose response is based on the Sao paper, the last reference from Korea, that tried to see if there was a dose response for the development of the methimazole embryopathy. And and it is based upon the cumulative methimazole dose. So certainly if you're on a lower methimazole dose, it's probably less likely that you get this. So the most important thing is that, and the ATA recommends this, since both drugs are associated with birth defects, and PTU is also associated with other types of birth defects that involve the sinuses and that involve the kidneys that are much less severe, that a woman has to be told that both of these drugs can be associated with organogenesis defects. And certainly the ones with PTU are less severe, but this should be reviewed, especially when someone is diagnosed with Graves' disease and is of reproductive age, when you're talking about the type of therapy that someone is going to choose. And so this is what led to the ATA recommendations that you use PTU, and they were really hesitant. I have to tell you, being on guidelines committees, and I know a number of you have worked on guidelines in different areas as well, 16 weeks is really a little long when I just told you the window of exposure was 7 to 10 weeks, but that's what happens on a guidelines committee. And certainly I don't keep people on this for 16 weeks. I sort of switch after 10 to 12 weeks. So that if someone is receiving methimazole and they're pregnant, they should be changed to PTU, and the dose ratio should be about 1 to 20 for methimazole to PTU. And then remembering the carbimazole. But that's where this all comes from, and I suspect you're all very fortunate here that you don't have to deal with the lawyers that would do this, because you don't have an FDA who has told you that you shouldn't be using PTU in the first trimester. Methimazole in the first trimester, excuse me. And the American College of Obstetrics and Gynecology has agreed with these recommendations. Okay, so let's talk about a case. So here's a 26-year-old female who was diagnosed with hyperthyroidism with Graves 6 months ago. These are her thyroid function tests. Her 3T4 was quite high, 5.3, upper limit normal of 1.7. Her total T3 was 450, so almost 2.5 times above the upper limit of normal. Her TSH was undetectable. Her TSI, which is the bioassay for cyclic AMP generation, was elevated, as was her TSH receptor antibody, which is the displacement assay, the immunometric assay, that was elevated as well. So she was started on propranolol because she was tachycardic, and methimazole at 20 milligrams a day. And then 4 months later, which is 2 months ago, you can see her free T4 and total T3 have normalized. Her TSH, not surprised, is still slightly low, and her methimazole was decreased appropriately to 10 milligrams. And now she calls you to tell you that she's 5 weeks pregnant. So what next? So here's the scenario. She's now 5 weeks gestation on methimazole with a TSH of 0.31, a free T4 of 1.5, and a total T3 of 200. So how many of you would, these are your options, decrease methimazole, change to PTU, check a trab, or change to SSKI. So decrease methimazole to 5 milligrams, change to PTU, check a trab, or change to SSKI. Okay. So I wanted to point out this checking the TSH receptor antibody. And unlike your patient where it sort of flipped over, but checking the TSH receptor antibody, and this was less than 0.9. Now, she's only on methimazole for 6 months, and there is also I actually read all the thyroid abstracts at this meeting earlier on. So there's actually an abstract here that's very nice that looks at the duration of methimazole to achieve remission. And studies have shown it should be 12 to 18 months, and this one showed it should be at least 6 months. But remember, she's already on it for 6 months. And so this leads to this question of, do all women with Graves' disease need to be treated with antithyroid drugs during pregnancy? So what we know about the activity of Graves' disease, which is what I was talking to you about, is, now let's go back 40 years to 1982. But one of the best papers from Japan from Dr. Amino and the group there that looked at, this was a total of 41 pregnancies followed from first trimester to postpartum. And what's shown here was the free T4 index, which is sort of like the free T4. But what you can see is there's an exacerbation in the first trimester, an amelioration. It gets better at the end of pregnancy with immune tolerance. And then we all know that Graves' disease can relapse postpartum. So if you actually look carefully at the first trimester, you can see that these were women who were in near remission or remission. So they either had just come off antithyroid drugs, or they were on a very, very small dose of antithyroid drugs. And although there was this transient increase, if you look at what is a pregnancy-specific normal, Only 2 women went above that. And those 2 women here got a little bit higher dose of methimazole. Remember, this is before the organogenesis stuff, for 2 weeks, and then it was stopped. So that the majority of these women did great. And if you actually look at what we know about Graves' disease, these are non-pregnant data, and this is actually taken from Scandinavia. But this is looking at over 200 patients with Graves' disease who had been treated with antithyroid drugs for 12 months, so the duration that we normally treat for, people are getting better. And then their drugs were stopped. And they divided them into 4 groups, TRAb positive, TRAb negative, and then also looked at cigarette status, because we know if you smoke, you're more likely to relapse. But what I'm going to do is just focus on the TRAb negative and get rid of the TRAb positive. And if you look at the TRAb negative women, and remember, you're not going to be in the first trimester for this much time. Like you're already diagnosing this early in pregnancy. And so if you look at, our patient is at 5 weeks gestation. Only 5% of those who became hyperthyroid within 8 weeks. So in other words, this is really, you're trying to avoid a time of organogenesis. So it sort of led to the concept of, is there a way that you can identify a cohort of women who are more likely to remain either mildly hyperthyroid or even euthyroid if antithyroid drugs are stopped in pregnancy. And so obviously we would like to have seen treatment for more than 6 months. Our patient was right at 6 months, so a lower chance of recurrence. If it's more than 6 months, our patient was right around 6 months, but generally shorter duration is associated with a higher chance of recurrence. A higher dose of methimazole is associated with a higher chance of recurrence than a lower dose. The TSH, obviously, if it's already low and you stop the methimazole, you're probably going to recur than if it's normal. And the most important thing is the TSI or the TRAb. So if that's still high, those women are going to recur, or they're going to become more thyrotoxic when you stop the methimazole than if it's normal or just slightly elevated. So in our patient then, her TRAb was negative. And so that raises the possibility that it could be stopped. So what happened was Dr. Wei Ping Tong and his colleagues in northern China actually published this paper just about 8 months ago, where they put this into practice. So they said, let's follow the ATA guidelines. And what they did was they had 63 women with Graves' disease who had been on antithyroid drugs for at least 6 months. Our patient was on it for 6 months. And they were on lower doses, so methimazole less than 5 to 10, or PTU less than 100 to 200. And then at less than 6 weeks or less gestation, they looked at free T3, free T4s, TSH normal or subnormal. So to be eligible to stop the drug, your free T3 and free T4 had to be normal, but your TSH could be normal or subnormal. And they also looked at TRAb. And they found that there was rebound Graves in 32%. But if you look at the patients who rebounded, it was those who had subnormal TSHs and positive TRAbs. If you looked at those who were TRAb positive but the TSH was normal, well, they rebounded too because the TSH receptor antibody was there. But if you looked at those women who were negative TRAb and TSH normal, only a very small number of those rebounded, like 13%, 1 in 10. So that's probably a population that you can identify where you could stop all antithyroid drugs early in pregnancy. And not surprisingly, they found that adverse events were higher if you rebounded. But in the first 2 groups, the TRAb was positive. So you probably would not stop the antithyroid drug. So this is a nice real-world application of what we discussed in the American Thyroid Association done prospectively. So antithyroid drugs in pregnancy, to think about when to stop them, is that if a patient is on that low dose, consider stopping, taking into account the disease history, the goiter size, the duration of therapy. Remember, 6 months is a little bit better. Results of use in thyroid function test, but the most important thing is probably the TSH receptor antibody measurement. And if stopped, those are the people you want to check quite frequently. You don't want to wait 4 weeks, but you want to check them quite frequently and extend it out a little bit further. So for your patient, I might check her thyroid function test now every 2 weeks, just in the beginning, and then you can go out a little bit longer. But I can't explain the flip, but she's there now, so that's good. Okay, so now we're going to go to the other scenario. So this is our same patient, but her TFTs did not behave the exact same way. So she's on methimazole 10 milligrams a day, and she calls you, and her free T4 is above the upper limit for the non-pregnant reference range. Her total T3 is 194, so just above the upper limit of normal, and her TRAB is positive. So again, free T4 just a little bit above the upper limit of normal for the non-pregnant reference range. Total T3 is probably in the normal pregnant reference range, 1.5 times the non-pregnant reference range, and her TRAB is positive. Her TSH is suppressed, so we have options of keeping the same dose of methimazole, increasing methimazole because her TSH is still suppressed, switching her to the PTU dose of methimazole, which would be 20 to 1 or 200 milligrams a day, dosed as 100 twice a day, or increasing her PTU to match a higher methimazole dose. So how many of you think she needs more anti-thyroid drug? How many of you think she needs the same dose? And all of you would keep her on methimazole because this is Taiwan. Which would be great. Okay, so fine, we're going to keep, so in the United States, we would keep her on the methimazole equivalent. And so this is just to remember, to remind us that fetal thyroid function reflects the same two things that affect maternal thyroid function. There's the inhibitory anti-thyroid drug and the stimulation from the TSH receptor antibody. And since we cannot measure fetal thyroid hormone, we use maternal thyroid function as the surrogate for what's going on with the baby. This is actually one of my favorite graphs, and Dr. Momatani has never published this. And I actually just saw her at the ATA in Canada. And I told her that she gave me this to use, and she still hasn't published these data, but they're great data because what she did was she had 249 women with Graves' disease treated to term. So they were on anti-thyroid drugs, some on PTU, some on methimazole. And what this is a correlation of the maternal free T4 and the fetal free T4. And what you can see is in the clinically relevant ranges that you might see for euthyroid women, but going up to thyrotoxic women. For each of those numbers, so euthyroid might be, around 1.2, 1.3. Women who are even not on anti-thyroid drugs, you might say that's an appropriate range. But what it is the fetal free T4 is lower than the maternal free T4 at just about all of those numbers. And I think this is probably, short of doing corticentesis to measure fetal free T4, these are probably the best data that really focus on the fact that whatever you're seeing in the mom, the baby's free T4 is lower. And so one of the things is that if you are going to potentially undertreat the mom, you want to know that there are no adverse effects for maternal subclinical hyperthyroidism. And this comes from my colleague, Brian Casey, who's an obstetrician in Texas, where he looked at a cohort of over 2,000 women, but he identified 433 who had subclinical hyperthyroidism defined appropriately as a TSH that was below the 2.5th percentile for gestational age. So the TSH was low, but the free T4 was normal. And he looked at all types of maternal outcomes, and you can see the subclinical hyperthyroidism, the women are shown in orange, the normal TSH women are shown in blue, and there were no increased adverse effects for anything. In fact, the normal TSH women were more likely to have gestational hypertension. So it at least makes you feel that if you're going to have a mom who has subclinical hyperthyroidism, these adverse effects should not be seen. So the therapy for maternal hyperthyroidism is really based on monitoring, and mostly now we obviously do the free T4. Initially, every 4 weeks, we can increase the duration if someone is doing well. But we use the non-pregnant reference range for the free T4 if we don't have a trimester-specific range. And for a total T4, we use 1.5 times the non-pregnant reference range. And we basically use the lowest dose to treat almost to maternal subclinical hyperthyroidism. So we keep it at the upper limit of the non-pregnant reference range, or even slightly above that. And remember, there's no adverse effects of that. So here's now given that we changed her to PTU, see that's why it's better to be treating this in Taiwan, because what happens in the United States is then you want to switch them back to methimazole, and there are no both the American College of Obstetrics and Gynecology and the ATA say it's not really clear that you should switch them back, because if you lose control, they could become thyrotoxic, and then that's worse for the pregnancy. So no recommendation can be made. So it's better to have just probably kept them on methimazole the whole time. But I actually do switch my patients back, and as I said, I do it at around 12 weeks. I don't wait till 16 weeks. So that brings up the next thing, is how we know how to treat the mom, but when do we have to worry about the baby? And that has to do with the fetal and neonatal thyroid function. And this just shows the change in TSH receptor antibodies in the first, second, third trimester and postpartum. And this mirrors that first paper I showed you that, we know Graves' disease gets worse in the first trimester. It gets better as pregnancy progresses, and then it can come back after the baby is born. So this is what's going on with the mother's TSH receptor antibodies, which we know can cross the placenta to the baby. So if we talk about who gets a TSH receptor antibody measurement, we're talking about predicting two things: fetal Graves' disease, which is in utero, and neonatal Graves' disease, which is postpartum. So that if a woman, there's a couple of scenarios that this can occur in. So you can have a woman who has active Graves' disease on antithyroid drug therapy. So we're going to be measuring the TSH receptor antibody in that woman. We're going to do it in the first trimester because we want to know if we can potentially stop it. In a woman can have Graves' disease that's been treated by either ablation with radioactive iodine or thyroidectomy, and she's on thyroid hormone therapy. So she no longer has a thyroid that responds to TSH receptor antibodies, so there's no bio measure of TSH receptor antibodies because she's athyroidic, either through surgery or radioiodine. So if we want to know the baby is going to be exposed, we have to measure it in that woman. But the one population we don't have to measure it in is if you have a woman who has Graves' disease who's in remission on no therapy, her thyroid's intact, and the fact that she's euthyroid is in essence telling you that she's not making TSH receptor antibodies. So that's a patient population that doesn't need it. And if you do it, the first time you do it is early in pregnancy. So remember, early in pregnancy it's highest. So if it's negative early in the first trimester, it's very unlikely to become positive later on. And so you're done. But if it's positive early in pregnancy, then you're assessing for the risk of fetal thyrotoxicosis, which becomes an issue from 24 to 26 weeks onwards. So you're going to measure it at 18 to 22 weeks to begin to judge if the baby is at risk for fetal thyrotoxicosis. And if it's positive then, you're going to start measuring it at the end of pregnancy, because if it's still positive, remember at the end of pregnancy everything comes down. If it's still positive then, these are the babies that can have neonatal thyrotoxicosis. So remember, you're looking for different things. The exposure here in pregnancy is fetal thyrotoxicosis, and then later in pregnancy it's neonatal. So remember, that's the pattern of the trap. Now it turns out that usually it has to be over 3 times the upper limit of normal to be predictive of fetal or neonatal thyrotoxicosis. And if it is, that's when we use our other tools to try to figure out what's going on with the baby. So that's when you're doing the fetal ultrasound to look for the heart rate, to look for growth, amniotic fluid volume, and fetal goiter, and we work with our maternal fetal medicine colleagues. And probably the most important thing here is the skeletal age. And it's really advanced skeletal age, which is most predictive of the fetal Graves. Okay, so fetal goiter, hypo or hyper, look at the mom. So let's say you do this, you find there's a positive trap, and the baby has a goiter on ultrasound. How are you going to tell if that goiter in the baby means that the baby has thyrotoxicosis, or perhaps the goiter in the baby is because the baby's hypothyroid, because maybe the baby has been overtreated through the transplacental passage of maternal antithyroid drugs. So again, look at the mom. So if a mom has active Graves' disease, and she's treated with antithyroid drugs with inappropriately normal thyroid function tests, or her TSH is 5 or 6, the mom's thyroid is telling you that the mom's thyroid is seeing relatively too much antithyroid drug compared to TSH receptor antibody, and so is the baby. So think about fetal hypothyroidism. If the mom has active Graves' disease and is frankly thyrotoxic, not controlled on antithyroid drugs, the baby's goiter is probably reflecting the same thing, think hyperthyroidism. And then most importantly, in the hypothyroid mom who's taking levothyroxine and you've been increasing the dose in pregnancy because she needs it, but she's making TSH receptor antibodies, those are crossing over the placenta and stimulating the baby's goiter. So here's the fetal thyroid. You can see it right here. There's the trachea. And this is, like in anything, this is sort of thyroid inferno. This is fetal Graves' disease at 32 weeks. On the other hand, this is what we're trying to avoid. And this was a case with the parents' permission, which is why there's nothing over the baby's eyes. This is a case when I was a fellow at the Brigham, where the baby was born with a TSH of 140. And mean, all of you can look at the mom's TFTs. That might be fine for someone who's pregnant. That is totally inappropriate for a woman who is pregnant. And so that baby was seeing the PTU that was causing the placenta. Now, fortunately, this goes away really quickly. We know how quickly PTU dissipates, so usually within 7 to 10 days of life, this will regress. But because of the trachea, I mean, here the baby's like this, but often they have to be laid prone. Okay. So reminder that even if someone requires antithyroid drugs, in a third it can be stopped by 32 to 36 weeks gestation. So to summarize, we talked about gestational thyrotoxicosis. Remember, emesis is not part of Graves', but look at that ratio. Use the ultrasound. The TRAB is negative. Hyperthyroidism, at least in the United States, PTU is preferred in the first trimester. Mild hyperthyroidism, withdraw if you can if the TRAB is negative, as shown by that study by Professor Tang. Use the lowest dose of antithyroid drug, because remember, the baby's going to see the same thing, and the baby's thyroid function is generally lower than the mom's. And check the TRAB in the first trimester. If it's positive, those are the ones you have to follow. If it remains positive, that's when you do a fetal ultrasound. And if it remains positive in the third trimester, that's when you probably have to check thyroid function tests in the first week of life once the maternal antithyroid drug has dissipated. And here's my same Robert, Indiana. Thank you very much. And we have 5 minutes more for questions.
Thank you, Professor, for such a wonderful talk. Now it's time for Q&A. Is there any question from the audience?
Nowadays, we are capable of determination of instead of just TSH receptor antibody, we can now determine TSH receptor stimulatory antibody. Do you recommend that we go specifically for that for a pregnant woman, or just usual?
Yeah, it's a great question. So there are 2 ways to do. In fact, that's the older test. There are 2 ways to measure TSH stimulating antibodies. One, which is called TSI, or thyroid stimulating immunoglobulin, is based on the fact that the TSH receptor is a cyclic AMP receptor. So what you actually do is you use, it used to be fetal rat thyroid cells, but you overlay the woman's serum on, you look for cyclic AMP generation. So it's a functional assay. So that's what you think would actually be the assay that you want to do, as opposed to a TSH receptor antibody, which is actually an immunometric assay. And so it just tells you that the patient, it could be anybody, has a protein that is able to bind to the TSH receptor. It doesn't tell you if it either stimulates the TSH receptor once it binds or if it blocks it. Because as you know, there's a form of congenital hypothyroidism, which is due to the transplacental passage of maternal blocking antibodies. So you would think the TSI is the better test. And if you actually go and look at papers, which was actually my job for the last guidelines, so some use TSI, some use TSH receptor antibodies. There are cases where the TSI is negative, the test that you think would be the good test, and the TSH receptor antibody is positive. So I actually measure both, and I don't have a good answer. It's sort of like your question. I don't have a good answer for it, except to say that our tests are not perfect tests, and that antibodies are heterogeneous, although theoretically for a functional assay, you could imagine if the antibody is heterogeneous, it might not be measured in the sandwich immunometric assay, but it should still be measured in a functional. But, again, they're not human thyroid cells, so maybe there's something about that woman's TSH receptor antibody that doesn't bind to that cell line. So that's my long way of saying I do both, and there are studies that look at both, and no study has reported one better than the other. Most studies use the TSH receptor antibody assay, which is not the functional one.
Okay, the reason I ask this is one is reimbursed in our system, the other are not.
So which is reimbursed? The TSH receptor antibody?
Yes.
So that's the one that most studies have used, and then I would just do that. And if there's something where it just doesn't make sense, but remember, you have your ultrasound. So if your TSH receptor antibody is negative, it's one of those rare cases, and the ultrasound looks like Graves' disease, then you can do it. You have other tools you can use.
Thank you.
But that's a good way to explain for people who are not used to both assays where those assays come from.
Uh, may I have your opinion on iodine intake for pregnancy women with hyperthyroidism or euthyroid growth disease or breastfeeding women with the above situation? Is it also 250?
Yeah, so it depends on who you listen to. The WHO, I think, is 220 micrograms a day, and I think the United States is 250 micrograms a day. But what they basically recommend is that a prenatal vitamin has 150 micrograms a day. So, there are places like in Japan, it's actually been studied that the average iodine intake is around 900 micrograms a day, which might be a little bit too much. I don't actually, made me think, I don't know what it is here because there is so much fish. So I don't know, and see, you don't eat quite as much. I don't think the diet has quite as much seaweed as probably, I don't know what the average dietary iodine intake is here. But the bottom line is that there are no differences in recommendations for pregnancy, even if you have Graves' disease. And certainly during lactation, that's the way the baby gets iodine after it's born, is through breast milk, which is why we all know when our patients are on low iodine diets for thyroid cancer, they can't have any dairy products because iodine is concentrated in dairy products and milk.
Thank you. Is there any other question?
I want to ask the professor about will you shift the PTU to late model in the second and the third trimester? Because one large study in Korea found that the possibility of fetal liver damage is lower than the congenital deformity. So they recommend that they will continue the PTU in all the pregnancy duration.
Yeah, so there,
your opinion.
so in Korea they're using PTU. I didn't know that in Korea they're using PTU. You're using the thimerosal throughout here in Taiwan, right? Which is what I would really like to do because it's so much easier to use. So if I understood you, it's hard with the mask. Were you saying in Korea they're recommending PTU throughout pregnancy? Yeah, I think all of these things are very rare events. So it's sort of how I talk about since I treat a lot of thyroid cancer, if you're giving radioiodine and people want to know, is there a risk of a secondary malignancy? And I know there's a poster here that says that there isn't, I told you I read the posters. But, there probably, if you look at large studies, there probably is an increased risk. This is just to digress, of stomach cancer, bladder cancer, and salivary gland cancer that is dose-dependent with radioactive iodine. But you're talking, it's the whole concept of absolute and relative risk. You're talking about a very rare event, like 1 in a million, and then it becomes 2 in a million. It's not like breast cancer where it's 1 in 10 women, and then it becomes 2 in 10 women. I mean, that would be unacceptable. So I think with all these things, yes, there are cases of fetal liver damage. There's this rare organogenesis, but it might be 1.6%. So it really, everything is risk-benefit, and your country, your society, your practice is going to decide on that risk-benefit. So I think you just have to have those open conversations with your patients. It just becomes a little harder in the United States when you have a regulatory organization that tells you not to do it. But if in my heart of hearts, this isn't taped, I would say I'd want to keep someone on the thimerosal, low dose, if I had it their entire pregnancy, because they take it. PTU is so hard to take, especially in the first trimester when it's multiple pills and people are nauseous. And I guess, there are cases of fetal liver damage, like very rare cases. And it probably is true that maternal liver damage is more common. It's very rare, incredibly rare. But if it were to happen, it's more common during pregnancy than in the non-pregnant state. But it's still incredibly rare. So I don't know if this change made sense.
Because of the time limit, I have to close this session.